All right, everybody, thanks for joining us today. Today we're going to talk about airway and diaphragm ultrasound. Our presenters are going to be two published respiratory point-of-care ultrasound practitioners, Dr. Awni Al-Subu at Madison, Wisconsin, and Dr. Ryan Desanti at Drexel University and St. Christopher's Hospital for Children in Philadelphia. So we're excited to hear what you guys have to say. Thank you for being here.
Right. Thank you so much, Luke, for the introduction, and thank you, Eric, and the group for asking us to present this. Let's make sure. Okay. So Ryan and I don't have any financial disclosures related to this talk, but I have an additional disclosure that I am not the expert on airway imaging, and many people, including Luke, who introduced me, are more expert on this. So through the presentation, if you have any input or comments, please feel free to share with the group. And also, I would like to thank Vidya and Luke for sharing some of their images and clips with me. So over the next hour, we will go over pediatric airway assessment and then assessment of abnormal diaphragm movements. And specifically for the first part, we'll focus on differentiating tracheal from esophageal intubation, identifying endotracheal tube location, and then we will move to how, using POCUS, we can recognize normal from abnormal movements of the vocal cord, and then look at some of the measurements and indices that we can use to assess the likelihood of a difficult laryngoscope. And in the second half of the hour, Ryan will take you on a journey over to talk about measuring diaphragm thickness, and then assess paradoxical or absent movements of the diaphragm. So it has been a tradition to start these lectures with a case presentation. I don't believe we have a poll ready for answering that question, but we'll come later and answer the question of this case presentation. So the case is about a 5-month-old male who was born preterm at 25 weeks gestation. Now with BPD and history of perinatal intubation, admitted to the PICU from an outside emergency room for management of acute respiratory failure due to presumed bronchiolitis. Got some fluids, antibiotics, I don't know why, but he got them, and then started on full mass CPAP of 8 centimeters of water with 0.4 FiO2 prior to transfer. Shortly after PICU admission, patient become more febrile with a temperature of 40.1 Celsius, worsening tachypnea to the 90s, tachycardic, worsening work of breathing with band retractions and desaturation, despite optimizing his non-invasive post-pressure ventilation setting. So he was intubated for mixed respiratory failure. So the question is, what will the point-of-care ultrasound show if the patient's esophagus is intubated? Will that be a jellyfish sign, a single barrel sign, double comet sign, or a barcode sign? Again, we don't have an active poll, so think about the answer. We'll come to it later. All right, so when we talk about airway point-of-care ultrasound, we have to, as everything else we do in POCUS, we have to know the sonor anatomy. And there are 4 areas that we will focus on, or mostly the literature focus on. For the first area that we image is the submandibular or suprahyoid, and this usually is used to assess the likelihood of a difficult airway. Then the second area is the thyroid cartilage and vocal cords, and this is used to kind of like assess vocal cord dysfunction or post-extubation stridor and laryngeal edema. The third area, which I will not cover in this talk, but it's the cricoid cartilage, which usually used for ET tube size estimation and cricothyroidotomy. And then the suprasternal notch area, which is used for ET tube placement confirmation and the depth of the ET tube. Now, people do it in different order. The way I will present it to you, that we will go from the suprasternal notch up and cover each area again, except the cricoid cartilage one. But before we dive into that, we'll just give a couple of comments on what probe to use for this one. And actually, the linear and curvilinear probes are the most commonly used ultrasound probes for visualization of the upper airway. And usually for superficial structures like the thyroid cartilage, the vocal cord, the trachea, and the epiglottis, as you know, are better visualized using a high-frequency linear probe, while the curvilinear probe is reserved for deeper structures, so at the tongue base and for certain airway measurements like the hyomental distance. I will talk about these, but I just want to put it out there before we start talking. And as you'll see from the next slide, we'll talk about selection of probe during each step. So we'll start with the suprasternal notch, which again is used for ET2 placement confirmation. And for this one, you will use the high-frequency linear probe, and you want to obtain a transverse scan just cranial to the suprasternal notch. And what you will see with this scan is that you see the picture where the probe is placed here. You will see the tracheal cartilage, which is in fluid here. Then you will see the thyroid gland, and then a posterior shadow down to the end of the screen, which is due to the air being in the trachea, which is called the single comet trail artifact, or people refer to it as, or in the picture as CTA. Now, if you move the probe, so you slide it to the patient's left side, as you can see on this image here, how we slide it to get an oblique view, you will see the tracheal cartilage over here, but you will see this collapsed structure, which is the esophagus, and then you will see the carotid artery. So in theory, combining these two views, you can assess if the AT tube is placed in the trachea or in the esophagus, but it's not as easy as it sounds, because if you get an image after an intubation, it will look like before intubation. And you can see that on the left side, there's a breathing tube there, and it looked like the image kind of the one before, yeah? However, if you get the images before, during, and after intubation, you might be able to show that if the breathing tube really went to the trachea or if it went to the esophagus. And over here on the right side, you see a clip that shows you the trachea, the thyroid, and the esophagus. And then the person who's intubating the patient went to the esophagus first. And you can see there is this shadow that was created in the esophagus area, and then went to the trachea and had what we call a snowstorm, which is a little bit of a brief flutter there. So again, let's see it. You can see a tube with air get into the esophagus get distended into a way you can like have a tail sign there. And then when they went through the trachea, you can see the flutter again there. We'll repeat it one time so you can look at it. Again, esophagus intubation. And then going to the trachea, and you can see the flutter of lights of signals there. Now, this is kind of like a gray scale ultrasound. And if you have challenges with that, you can use the color Doppler imaging. And this has been proposed in some studies. And what you will see when you do that is that you will see a color signal coming below the tracheal cartilage. And that will indicate that the tube really went through that area. Now, how helpful is this? It's still kind of like, under investigation, but Gildia and her colleagues a few years ago looked at this, and they recruited 38 adult patients, and they did the color Doppler intubation and grayscale ultrasound during intubations, and they did not, in their conclusion, find that there was significant help with correct AT tube placement. So it's still an area of investigation, but if you're kind of like wondering and not sure about it, you can add it to aid you with that, but it will not make a huge difference. Now people continue to look at tricks. Okay, we did the grayscale ultrasound, we did the color Doppler, is there something else? And people went and tried to do airway imaging while filling the cuff instead of air with the fluid. And you can see on the left side here a static ultrasound image where here's the tracheal cartilage, and you can see the cuff here is filled with saline. So it's an anechoic or black area anterior to the trachea. And if you do it in a dynamic view, you can see over here on the right side that the cuff of the tube is getting filled with saline, and you even see the air while it's going with the saline into the cuff, and then the cuff gets distended, and you have that anechoic area there. Now people doing it, it's a little bit, you're filling the cuff with the saline versus air, so it needs some workflows around it. But a group in 2020 published in Critical Care that they'd done it, and they'd done it on 75 children, and they were able to identify intratracheal tube in the trachea or the suprasternal notch view in 70% of the patients, and that gives a sensitivity of almost 94%. Now, I just want to give another comment. I talked briefly about esophageal intubation, but I want to do it with kind of like, again, a view where you can see static and dynamic views there. So again, we said the esophagus is collapsed, so there's no air. So if you have a tube in it and you do a static image, you will see that you will have two tail artifacts, or what we call it in airway ultrasound, double comet artifact or double barrel artifact or double track artifact sign. And on the right side, you can see a dynamic one again, where a breathing tube was in the esophagus and then got removed. And you see that there was this double sign and then double barrel sign, and then it disappeared. So now we had all these kind of like good findings that we can use at the suprasternal notch. The question, we knew that ET tube is in the trachea. What else we can use it for, or how can we integrate that to kind of like confirm the ET tube depth? And Senussi and his colleagues in 2020 really came with this nice study protocol. And I will show you the results of this in the next slide, but they used it to kind of like see, okay, if we follow these certain steps in this protocol, can we confirm breathing tube placement or the ET tube placement? And their protocol is easy. You can like go, you do the suprasternal notch ultrasound, and if you have a double comet or double barrel sign, then you are most likely esophageally intubated, so you need to retract the tube and try again. If you don't have that, then you're good. And then you go and do lung sliding, which Brian talked about a couple of weeks ago. And if you have sliding on the right, but not on the left, then there is a high likely that you are main stemmed and you need to adjust the ET tube. Now, another thing that they said, if there is no sliding at both sides and you don't have the double comet sign, still consider esophageal intubation. Yes, you can see no sliding with the pneumothorax and other conditions, but usually it's rare to have bilateral pneumothorax. And also you have the lung pulsation that hopefully can help you differentiate between that and esophageal intubation. So how did this protocol perform for this group? And they recruited 118 adult patients, and they had 1 esophageal intubation and 5 main stem intubation. And they were able to detect all those by ultrasound, except I think 1 or 2. So they concluded that the use of focus to confirm ET tube depth is 97% sensitive, which is really a good one. Now, after this study, there was many studies before and after it too. So these are 2 systematic reviews, and I know they're not very clear on your screen to see. But overall, the message from them is that the combined sensitivity and specificity for point of care ultrasound to detect ET tube placement and depth is north of 97% on both meta-analysis. So going back to the question, what will the ultrasound show if the patient is intubated? And I'm sure you all guessed it the first time. It was the double comet sign. All right, now we'll transition to the second area where we want to image, which is the thyroid cartilage, which again, this helps us with vocal cord movements and dysfunction. So again, with this one, you want to use a linear probe. You want to obtain a transverse scan just at the thyroid cartilage level. And once you're there, you just start turning up your gain until you see a very bright symmetrical structures on both sides of the midline. And these are the vocal cords, and of course, next to them is the false vocal cords. And on the scheme here, or the picture here, you can see these are indicated by the light blue. Then you see the arytenoid cartilage in green, and then you see the thyroid cartilage in yellow. And then this will help you to evaluate the vocal cords. So here I have a couple of static images from a 3-month-old premature boy. And on this graph, you can see the vocal cords are closed. So the vocal cords are adducted. And you can see the hyperechoic midline structure here, which is the true vocal cords. And that tells you that the vocal cords are adducted. But then with phonation, the vocal cords get open and you can see how these two hyperdense structures or the vocal cords really moved apart. Now, how does that look with a dynamic view? So you see the thyroid cartilage again here, you see the vocal cords here, and then you will see that with phonation that the patient is moving those cords and they're opening and closing there. This is on the left, another image of a normal vocal cords. Again, you see the structure, thyroid cartilage, the vocal cords, the arytenoid cartilage, and you can see they're separating, but on the right side, it's not symmetrical, yeah? So there's a failure of the left vocal cord to abduct there. Now, using the same view, but while patients are intubated, you can use that to assess for laryngeal edema. And what you want to look at the same level is that you want to see the thyroid cartilage, then you want to see the vocal cords, and then you're looking at this hyperechoic line at the air mucosa interface. And that's what is described in the literature, and our colleagues, Vetted and Luke from Alabama, really published on that. Is called the laryngeal airway column width, and that what you measure in order to assess for laryngeal edema. And I like this drawing here because it's going to like simplify it for you. So you really, this is the airway column. This is what you want to measure. And then you have the thyroid cartilage, the vocal cords, and you really focus on measuring that way. Now, again, when first time I read that, I'm like, okay, I'm not clear of what I'm seeing and what I'm evaluating. And I like this picture from this publication, 2006, that again shows you this is an ET tube with a deflated cuff, balloon cuff now. And this is the area where you're really trying to measure. So it's the widest area that you can measure by ultrasound to assess the LACW there. And when we do that, because there's a breathing tube, we want to do that with a cuff inflated and with a cuff deflated. And then we will talk about it in the next slide. We will look at the difference to assess for the possibility of having post-extubation stridor or edema. But one thing that the literature talk about is the air mucosal interface. Usually can, like, if you have a inflated cuff, it looks more of a cylindrical or rectangular shape, while when it's deflated, it looks a little bit trapezoidal shape. However, in pediatrics, it seems it's a little bit harder than adults, and then you just have to mark your images and know when you did those. Now, when you do the difference, so you can like measure them inflated and deflated, and then you can measure, measure the laryngeal air column width, and then you do the mean of LACW while the cup is inflated minus when it was deflated. And how did that perform? This is a study that was published just very recently by Luke and Vidit and their group. And they enrolled 53 patients who are less than 5 years of age. And 18 patients, so 34% of their patients experienced post-extubation stridor. And 3 of those, so approximately 5%, were reintubated for severe subglottic upper airway obstruction. And what they found that the LACW was significantly lower in the stridor cohort, and that a cutoff of less than 0.47 millimeter can predict post-extubation stridor with an area under the curve for receiver operation curves of 0.94, which correlated with sensitivity and specificity of around 90%. Now, a few years ago, there was this study that by Ding and their colleagues that looked at this in adults, and they had planned 51 extubations, and they measured the LACW 24 hours before extubation. And in their cohort, 8% only of their population, which is not surprising, these adults have stridor, and 10% of all extubations were reintubated. And for these adult patients, they found that if the LACW-D was 1.5 or higher, that was not associated with stridor, but it was lower. It was associated with having the stridor. Again, only have 7.8% patients, so roughly 3-4 patients who had post-extubation stridor. So not the best study to look at, but that's what out there. So now we'll transition to the submandibular suprahyoid view. And this is the view that we use mainly to assess the likelihood of having difficult airway. Now, when you look at literature about this area, there is a lot of indices that people really evaluate and measure. But the most common ones that really is out there is the hyomental distance ratio, and we'll talk about that. But it is a measurements that help with estimating the ability to do atlanto-occipital extension and also tongue displacement with its position and help with the glottic view while you're doing the laryngoscope. Also, there's the distance from skin to hyoid, skin to epiglottis, and skin to anterior commissure vocal cords, and all these help with the soft tissue and at the level where the airway need to be manipulated. And finally, the other one that literature looks into is the tongue thickness, and that, of course, evaluate whether there's limitations on the oropharyngeal space, and could any of that restrict laryngoscope. As we all know, a small oral cavity could impair your instrumentation and visualization. So first, we'll start with how to get the submandibular area mid-sagittal scan. So, and this one is how you get what called is hyomental distance, yeah? So you put the curvilinear probe in the submandibular area, and then you look for in the center, we will find the tongue, and then these bony structures with hyperechoic structure there. that has posterior acoustic shadow, and then you measure the difference between the mandible bone and the hyoid bone. And then you can like to do the tongue thickness, you just measure the hypoechoic muscle that is shown in the picture here, and this is how you can get this hyomental distance and the tongue thickness. Of course, this is a static image, so how it looks like when you do it in a dynamic one. And again, you can see the mandible with the acoustic shadow, the hyoid bone with the acoustic shadow, and then the tongue, and you can do your measurements there. Now, this is an image that show you how to obtain the hyomental distance at both in neutral and hyperextended position, because this is what literature tried to do. And I will show you in the next lecture, next slide, that the ratio is what mainly used to assess difficult airway. So again, you have the neutral position, and you can measure the hyomental distance and then the tongue thickness, and then you do the hyperextension and look at that. And in Petrosur in 2018 looked at this, and they found in adults that a hyomental distance of less than 4.47 centimeters, a neutral position, and less than 5.5 centimeters at extended position had both a specificity of around 50 and 70%. Studies looked at the ratios between those, and the ratio that adult literature is looking at, or kind of like considering, is less than 1.2 when you do the extended over the a neutral position. And Vidit and his group is looking into pediatric population, and hopefully we'll have some results very soon from that. The second area that you can look into is the skin to hyoid bone measurements. You can see, you can just measure the distance. So using the submandibular view to get a transverse plane, you get the image at the hyoid bone, and then you just do direct measurements there. In adults, anything less than 2.8 centimeters can potentially use to indicate there is a likelihood of difficult laryngoscope. This is a dynamic clip that show you how to get that view at the submandibular one using the transverse plane. Now, this is a view that we did not talk about when I started the sonoanatomy, but at the inferior part of the submandibular view and a transverse plane, you can get the epiglottis. And this is an image that is obtained as showed here, just under the hyoid point, and you can look at it. And once you identify the epiglottis, you can do the measurements there. It's not that much used in pediatrics, so I did not focus on it initially when we talked. Then you have the a view that you want to do the cricoid view, the thyroid membrane view, where you want to look at the vocal cord and distance from skin to the anterior commissure vocal cords. And this one, again, similar to the distance from skin to hyoid, in adult patients, they consider anything that more than 28 millimeters is an independent predictor of difficult laryngoscope. However, all these studies are small numbers. They are not having the same approach and protocol. So recently, Eric and Vidit put out a nice systematic review and meta-analysis that looked at association between different indices that measured and difficult laryngoscope. And actually, they looked at 27 unique indices in that meta-analysis, but they divided them into three groups: the anterior neck soft tissue thickness, the oral space domain, and then the anatomical position domain. And what they found that the anterior neck soft tissue thickness indices had a sensitivity of 76% and specificity of 77% with an AUROC of 0.83. Compare that with the oral space. It has similar sensitivity and specificity, a little bit lower sensitivity at 53% and similar specificity at 77% with an area under the curve of 0.73. And then the anatomical position domain had the best AUROC of 0.87 and a pooled sensitivity of 74 and specificity of 86. But what we learned from this meta-analysis is one indices is not enough, and we need to kind of like look at multiple views, and we still need to look into that a little bit more. This is another meta-analysis done a couple of years before that, and it shows similar things where there is some indices like the distance from skin to epiglottis and anterior neck soft tissue thickness at the hyoid bone that can perform a little bit better than other indices, but still we need a little bit more work on that. Now, I really like this approach that was, this is for adult patients, published by Lin in 2023. And they call it the DARES protocol. And what they do, kind of like they start with the thyroid view and then go into the suprahyoid view. And then they do the hyomental distance and tongue thickness and neutral hyperextended and then in flex positions. And they use it kind of like as a way to see if they can predict difficult airway or not. Again, this is their own way. They did not validate that. I did not see results based on that. Maybe I missed it, but when I was looking earlier this week, I did not. So that's what I have. It's kind of like a really very interesting field. There's a lot of advancement happenings and some exciting studies going on. And it's something that as a community, we can look into and use more. So I'll stop here, and given that I went over time a little bit, so sorry, Ryan.
No problems.
You can go ahead and then maybe we can take questions afterward.
You're able to see the screen, correct?
Yes.
Okay, so the goals for the second half of the presentation are just to differentiate normal from abnormal diaphragm movement. This includes measuring diaphragm thickness, and then identifying paradoxical and absent movement of the diaphragm. So coming back to the case, the patient ended up being intubated for respiratory failure for 2 weeks, and this intubation was complicated by ventilator-associated pneumonia and fluid overload. The patient was weaned down on ventilator settings to minimal settings and is being evaluated for possible extubation. The patient developed tachypnea and desaturations when he was weaned from SIMV PRVC with a tidal volume of 5, PEEP of 5, and respiratory rate of 25, and pressure support of 10, and placed onto CPAP of 5 centimeters of water. So one clinical question, which ultrasound technique would be most helpful ancillary study in determining the patient's likelihood of successfully liberating from mechanical ventilation? Tracheal ultrasound, vocal cord ultrasound, lung ultrasound with M mode, and diaphragm ultrasound. As Awni had talked about, vocal cord ultrasound may be beneficial in estimating how much edema there may be, but the answer to this question is diaphragm ultrasound, which is what we're going to be talking about. In the literature, there are many different indications for using diaphragm ultrasound. Some of the most relevant to the pediatric intensive care unit are following cardiac surgeries to monitor for diaphragmatic paralysis, dysfunction or atrophy following mechanical ventilation, and positive pressure ventilation, as well as studies which have looked at predicting illness severity, need for respiratory support, outcomes in bronchiolitis and pneumonia, as well as studies which have looked at weaning and extubation. So in general, there are two approaches to the diaphragm evaluation, which have been described in the literature. The first is looking at the diaphragm thickening fraction, and the second is looking at diaphragm excursion. And we'll talk about both of these. Of course, as we know, the diaphragm is a curved dome-like muscular structure, which is lined superiorly by the parietal pleura and then inferiorly by the peritoneum. We can see the dome-like contour in this ultrasound image. And so we are able to measure the diaphragm thickness, which is a static measure of the distance between the pleural and peritoneal layers, and then use the diaphragm thickness during inspiration and expiration to measure the diaphragm thickening fraction, which can be used to assess the diaphragm contractility. And so we do this in M mode. The diaphragm thickening fraction is then the increase in thickness during inspiration and expressed as a percentage. So we take the end inspiratory diaphragm thickness, subtract the end expiratory diaphragm thickness, divide by the end expiratory diaphragm thickness, and multiply by 100. So in order to measure the diaphragm thickening fraction and diaphragm thickness, we typically will use the linear transducer, place it at what's called the zone of apposition of the diaphragm in the chest wall. This is typically between the 8th and 10th intercostal spaces. And then place the diaphragm, and this is a little bit variable in the literature, somewhere between the anterior mid-axillary lines, mid-axillary line, or at the posterior axillary line. So anterior, between the anterior mid-axillary line, at the mid-axillary line, or at the posterior axillary line. And again, this is with the linear probe, with the probe marker facing towards the patient's head. Should get an image which looks similar to this. You have subcutaneous tissue, you have a rib, and then you have hyperechoic pleura, hyperechoic peritoneal membrane, and then between the pleura and peritoneal membranes are the diaphragm. If we place M-mode cursor at this region of the diaphragm, we can watch the change in thickness during inspiration and expiration and measure these. So as the diaphragm thickens during inspiration, there will be a greater distance between the pleural and peritoneal membranes, and then they will return to baseline during expiration. So for this example, we take 0.48 centimeters, which is the inspiratory distance, subtract the expiratory distance, 0.18, divide by 0.18, and then multiply by 100. This is an exaggerated example, get 167% thickening fraction. This is another example of this. Again, the subcutaneous tissue, the rib, the pleura, peritoneal membrane, and diaphragm, and then M mode of the diaphragm, looking at the thickness during inspiration, which is 0.427 centimeters, and then the thickness during expiration, 0.333 centimeters. And again, plugging these into the equation, we will get 28% diaphragm thickening fraction. Unfortunately, there are no well-established normative reference values in pediatrics for diaphragm thickening fraction. Most of the studies which have looked at it look at the excursion and the thickness without calculating necessarily the thickening fraction. Most of the research thus far has actually been done in term and preterm infants. There is a recent publication here from 2023, the European Journal of Pediatrics, which looked at the diaphragm thickening fraction in healthy children and found it decreasing slightly from 27% thickening fraction down to 21%. This is age 0 to 6 months up to 5 to 8 years. Not statistically different though. One of the issues, though, which we run into, especially in the intensive care unit, is that these values are probably dependent on the loading conditions, meaning the type and amount of respiratory support that the patient's on. So, for example, this article, data from Dr. Glau in 2020 from CHOP showed that within 36 hours of intubation, patients only had a thickening fraction of 9.7%, whereas within 24 hours before extubation, it was about 15%. And so this demonstrates changes in the thickening fraction based on the mechanical support and probably the sedation that the patient's receiving. And so here's an example demonstrating just the range of studies which have been done and how different authors have looked at different parameters as well as different age groups. So we have the thickening fraction in healthy children spontaneously breathing. One study is looked from 0 to 8 years, one study 8 to 10 years, one study 0 to 6 months, one study 2 to 4 years, one 6 months to 1 year, one study 0 to 6 months, and then another study 2 to 4 years. So unfortunately, there's not yet any well-defined parameters or populations in which this has been validated for. And I apologize, the second part of this graph is in ventilated children. The first part is healthy children spontaneously breathing. So just the two first studies, spontaneously breathing, and the rest of them ventilated children. So different parameters that have been studied in pediatrics, as well as different age groups. So back to the case, based on low ventilator settings, extubation readiness trial and discussion with the parents, the patient ended up undergoing a trial of extubation, following which he did have recurrence of his tachypnea and work of breathing and was placed onto BiPAP with stabilization of his respiratory status. And so one thing that might be considered, in addition to the diaphragm thickening, is diaphragm dysfunction, which is the loss of the muscular force, which is generated by the diaphragm during contraction. This is common, of course, in congenital heart surgeries, as well as neck and thoracic surgeries. Can also be seen in critical illness, neuromyopathy, and prolonged mechanical ventilation, so-called ventilator-induced diaphragm dysfunction. Characterized by a decreased, absent, or paradoxical diaphragm movement during inspiration. Unfortunately, as with the diaphragm thickening fraction, there are no standardized methodology for ultrasound assessment of diaphragm function. The most kind of commonly described in the literature do use either curvilinear probe or phase array probe. Typically would start out in the transverse plane in the subxiphoid area, which will allow us to evaluate both hemidiaphragms simultaneously. And then move towards individual evaluation of the left and right hemidiaphragm. Can be done subjectively or objectively using diaphragm excursion. The diaphragm excursion is a measurement of how much the diaphragm moves in the sagittal plane during inspiration and expiration. So the location of the measurement is done in different places by different authors. In the subcostal region, typically somewhere between the midclavicular and anterior axillary lines. Some authors will describe it as being in the midclavicular anterior axillary lines on the right, a little bit more posterior on the left, anterior and mid-axillary lines on the left. But again, this is variable study to study. Of course, as we know, during inspiration, the diaphragm should move caudally or towards the transducer. And then in expiration, the diaphragm should move cephalad or away from the transducer. So it should move towards the feet, towards the transducer during inspiration, then away from the feet, away from the transducer during expiration. Of course, something to think about is that different conditions which we might see in the intensive care unit might change the location of the diaphragm or how it's moving, such as with air trapping or volume loss. These may result in abnormal shape or locations of the diaphragm. So this is an example of midline transverse view using phase array probe. So the phase array probe placed in the midline transverse subxiphoid region allows us to look at both the right and left diaphragm simultaneously. And then during inspiration, the diaphragm should move towards the ultrasound probe and away during expiration. And then moving towards the right and left side. Again, these are done individually. Somewhere between the mid-axillary and anterior axillary line. On the right side, anterior and mid-axillary lines on the left, with the ultrasound probe marker facing towards the patient's head, or 12 o'clock. We should get an image which looks like this. On the right side, we'll have the liver, then the diaphragm, and then the lung. On the left side, the spleen, diaphragm, and lung. And then we can visually look at discordance between the movement of the diaphragm with respiratory effort. And this would demonstrate diaphragm dysfunction. We can also look at the diaphragm excursion using M mode. Again, this is the amplitude that the diaphragm moves on the vertical axis from baseline. And then we can measure it on M mode. And so again, here's our ultrasound image. We have the probe at the top, the solid organ, and then the diaphragm. And in M mode, we have this hyperechoic line, which corresponds with the diaphragm. During inspiration, the diaphragm moves towards the probe with a positive deflection, and then moves back towards the baseline during expiration. Ideally, this would be performed on a spontaneously breathing patient, of course. And so here's another example of the M mode imaging. So we just measure the maximum height of inspiration, gives us the diaphragmatic excursion from the baseline. Different studies have looked at different outcomes and have found that diaphragm dysfunction is associated with longer duration of mechanical ventilation, increased likelihood of extubation failure, increased PICU and hospital length of stay, as well as increased mortality. Unfortunately, and similar to diaphragm thickening fraction, there are no well-established reference values for a normal diaphragm excursion, and is probably going to depend on the specific patient population and conditions under which you are ultrasounding the patient. Those studies have compared the left and right diaphragm in patients at the same time and have not found a significant difference in the diaphragm excursion between the right and left hemidiaphragms. So we should be able to use comparison between the right and the left at the very least to evaluate for unilateral dysfunction, paralysis, or paresis. And so here is an example in M mode where during inspiration, the diaphragm actually moves away from the ultrasound probe, which is consistent with paradoxical diaphragm movement during inspiration. And then here we have an example where the diaphragm does not move at all during inspiration. And this is consistent with diaphragmatic paralysis on that particular side. If there are any questions, I think Awni and I would be happy to take them. Also, probably Luke and Eric are also well experienced with this and might be able to answer some as well. Thank you, guys.